My name is Nima Jokilaakso, and I'm here to present to you Dr.Maombi, the mobile healthcare application for developing countries. This is what we believe in. Provocative, maybe. But we think it's easy to build an app, but it's much harder to understand a need. So what is the need we are targeting? There's a healthcare crisis going on, particularly in sub-Saharan Africa. There's 30,000 patients to one doctor, only in Tanzania. What does this mean? It means that 1 in 4 patients will not get sufficient healthcare because of this number. Now that correlates to 20,000 patients a day. People like Abasi. Abasi is a young boy, but he's being ill. So his mom takes him to the healthcare center, and they meet the nurse. The nurse tries to do her best, but she doesn't know what's going on. And there is no doctor. Going to a doctor in a big city is too expensive and takes too long time. And that's where we come in. Because this is what we do. We give patients access to doctors in the big cities. This is kind of obvious, right? We give access to doctors. This is what we do. How does it work? Well, now, with Dr. Maombi, which I can demonstrate to you afterwards, the nurse, when meeting Abasi, can add the patient information, health status, add images and audio. Then send a request with all this information, and it will be sent to the server and made accessible for a group of certified doctors. So these doctors can make an assessment and reply. And when they reply, the nurse can now take appropriate action, such as putting in medical treatment or making a correct referral. And we have learned this together with our Tanzanian partners and the local healthcare providers. The guy in the middle is Kasim, one of our team members, showing how this works. So we have a group of dedicated people in Stockholm, Sweden, and Dar es Salaam in Tanzania. And this spring, we performed our field test where we could prove that the technology works and the need is there. And they liked it so much that they're still using this. This one phone we took down there, we're generating 5 to 10 cases a day. That's daily feedback. So what's the next step? Well, this autumn, we are going back there, this time to 20 healthcare centers, to verify the need, try out a sustainable business model. And this has been funded by the National Aid Agency, and we're collaborating with the World Lung Foundation and the Muhimbili University Hospital. Because this is what we do. We help a little boy. Thank you.
I've got the first question. Have you talked to the Gates Foundation? And if so, what have they said?
Not yet.
Okay.
Great energy, and you're solving a commendable problem. So it's a real thing. So commend you on that. A couple things. So the price point. Seeing we were talking about a little earlier, it seems a bit expensive for the market, right? Do they have? I think it's $35. Do they have $35 to pay for this? And so that's the first question. And then the second is, You spoke about the doctor to patient ratio. What about the nurse to patient ratio? Right? Are there enough nurses to support this solution?
Okay, good. So there was two questions. One is kind of, what is our revenue model? How do you make it actually sustainable if there is enough? Can they afford it? And the second question was nurses, number of nurses. I would like to answer the second first. Nurses, yes, there is enough nurses. They could of course, what?
What's the ratio?
I don't know the ratio, but there's 10,000 nurses in total. I mean, it could be more, but that's not the pain. That's not where it kind of hurts. There's enough nurses to take in patients, but they don't always have the sufficient medical training to take care of all of those.
We should know that stat.
I will. When it comes to revenue, this is why we're really talking to the Ministry of Health, because when it comes to cost for a doctor's visit, that's $0.32 US. And children, pregnant and elderly are subsidized by the government. But the traveling cost to go to a big city hospital, that's $5 one way. So that's a lot of money. That's a week's salary. It sounds kind of like crazy, but $5 is a week's salary. So of course, when we think about our revenue model, we don't want to go in there and like have a very high price so that money is actually being pulled out of the community. We want to create a business down there that generates jobs and is kind of growing organically. So that's the discussion we're having. It's tough. You can't just go in there and say, this is what we charge. So good question, but I can't give you a one fixed number.
Sarah and then John.
Is there any big data element on the back end where you could actually cut out the doctors entirely? It seems like if you've already had, some form that has the exact same information a doctor has said, that we need to use that you could kind of create more automated responses, which would increase the ROI.
Very good question, and I see this happening a lot when it comes to health apps. We're actually kind of doing it a different way. We don't really believe that things should be automated. In our first version, we actually thought there would be some image analysis software so that some of those images taken could be analyzed automatically. But the way the healthcare system works, the healthcare provider don't trust it. And if they don't trust it, then we shouldn't be doing it. So one of the feedbacks we got that it was actually better to do audios, for example, recordings, and have that kind of patient, nurse to doctor interaction. And then some people say, well, why don't they just make a phone call? But that's because you don't know who to call. You don't know, and then when you call, the doctor might not be available. So when it comes to big data, the opportunity we see is actually in that the government will have some, if we can generate statistics, they can start to do predictions. Well, are we seeing an epidemic in this region? How is it spreading? That's the kind of big data we are interested in. But we're not doing it right now.
John, and shorter answers.
Okay, sure.
That's okay.
Yeah, stupid question, Bobby. Do you actually have 3G coverage in all areas, in these rural areas that you want to cover?
We have actually sufficient coverage. So that means that when we have our meetings with our colleagues, we actually we have Skype meetings, sometimes even video conferences. It's kind of amazing because, it doesn't feel logical. You think like you go to a rural area, people are super poor, hard to have any food on your table, but actually the coverage is good enough to do this. Yes?
We're going to switch the feedback. We'll go Alan, Willis, and then John, please. Alan, feedback?
Sure.
Johan,
Yeah.
sorry.
Yeah, so I think that you had a very interesting and passionate presentation, but in a very dispassionate view of what you're trying to do. This is telehealth, right? I mean, this is essentially telehealth. So for me personally, I didn't need all the stories and all of the theatrics. It's just we know that this model works. It works here in the United States, and if you can replicate the model at a cheaper scale, with maybe more basic services, that it could possibly work in Africa. And I think that if you just show how this works, and you're just exporting or importing a model that already works, and you've mitigated a lot of risk, then it's a very clear-cut investment decision.
So I tend to echo the fact that to me the theatrics was sort of unnecessary, because often entrepreneurs confuse theatrics with energy, and it takes away from the core of what you're trying to do. You're doing great work here. Let that speak for itself. You don't need to sort of oversell it. It sort of turned me off a little bit initially before I knew what you were doing. I'm just like, oh, what's like all this drama about? So keep that in mind. Second, so you're obviously doing great work. Now the question for me is this a nonprofit? Should it be a nonprofit, or should it be a for-profit company? You are targeting, I mean, at the end of the day, you've got to sort of search deep down within yourself and understand what is more important to you, making money or doing good. And if it's doing good that you want to do, then the better or more successful execution of this may be as a nonprofit. Maybe, I'm not suggesting it is, because you may find greater funding sources and so forth to take this to a broader region, maybe Sub-Saharan Africa, maybe in India, maybe China, maybe all these countries as well. But I would encourage you to think, first of all, dig deep down and figure out, what turns you on about this business. And then based upon that, create the business model. I wouldn't necessarily just default to try to do a for-profit in Sub-Saharan Africa, which could be hard to do.
John?
Yeah, that wasn't clear to me at all. Who's going to pay for this stuff? And so you're doing a lot of good testing. You're launching some new. You're saying you're looking for the business model, and that was, my feedback is, well, how are you looking for the business model? What are you testing to establish it? So yeah, maybe it's not a profit, but you sound like you think there's a for-profit model there. So what are you going to test? It would be good to know in the presentation.
Okay, we're out of time for feedback. We're going to vote now on the count of 3.